Bismillahirrahmanirrahim. Assalamu alaikum. I'm Dr. Hira Ahmad. I'm working as a cardiologist in the city hospital. We are going to discuss the common ECG patterns today. So let's begin. What's an ECG? In simple words, ECG is the recording of the electrical activity of the heart. Don't get overwhelmed by looking at this ECG. Just focus on the circled areas, the red areas which I have circled. Just if you are able to appreciate the name of the patient, Ghulam Muhammad, this is the name of the patient. Unfortunately, the age is not mentioned in this ECG. The time and date you can appreciate at which the ECG was taken. This ECG was taken on May 3rd, 2018 at 2:49 p.m. So the purpose of putting this slide is to emphasize on the importance of the demographic data. The importance of the demographic data cannot be more emphasized. Now there is another thing. If you can appreciate, there are some calibrations at the extreme left end of the extreme left end of this slide. It's written that 10 mm per millivolt. These are the standard calibrations of an ECG. So whenever you are reading an ECG, make sure the calibrations are correct. 10 mm per millivolt is the voltage of the ECG and 25 mm per second is the speed of the ECG, and this is a standard worldwide. So before you jump into reading an ECG, make sure you have gone through the demographic data, because which might be a pathology in an adult patient will be a normal finding in a neonate, such as a heart rate of 150 or 160. So after you have gone through the demographic data and the calibrations, please have a look at the calibrations again. You can move on to the next to the reading of the ECG. Well, this is how a normal 12 lead ECG looks like. There are some chest leads and the limb leads. We will take one complex. This is a complex, the P wave, the QRS and the T wave. What does the P wave denote? A P wave denotes the depolarization of the atria. So anything that goes wrong in the atria will be visible in the P wave. For example, if there is something wrong in the right atrium, we will have a tall P wave. If there is anything wrong in the left atrium, we will have a broad P wave. Next is the QRS complex. The repolarization of the atria gets embedded in the QRS complex, so we don't get a wave for the repolarization of the atria. The QRS complex is the depolarization of the ventricles, and similarly T wave is the repolarization of the ventricles. Anything that's wrong in the ventricle will appear in an ECG in a QRS complex, and any pathology that delays the transfer of the current from the AV node into the ventricles will give a pathology in the QT interval. If at any point you find anything which is confusing or you are not getting, please feel free to interrupt. Should I move to the next slide? Before I move to the next slide, please appreciate that there are some large boxes in the ECG strip and then there are some small boxes in the ECG strip. Are you all able to appreciate the large and small boxes? So it's important. Sir, actually I cannot move the cursor. Okay?
Small boxes and
or large boxes. So each large box is equal to 0.2 seconds. We as cardiologists, we have to memorize it. So we know that a large box is equal to 0.2 seconds or equal to 200 milliseconds. Similarly, a small square is equal to 0.04 milliseconds or 40 milliseconds. So when we talk about ECG, we talk in terms of small boxes. because it is easy to understand and it is easy to talk about. Now we can move to the next slide. As I mentioned earlier, it's a normal 12 lead ECG. We have the chest leads in it, and then we have the limb leads in it. We look at the heart from all angles. When we are looking at the heart, in chest leads we are looking at the heart from the front, and in leads 1, AVL, and V5 and V6 we look at the heart from the lateral side. And then we have the lead AVR. When we place the AVR, it's in the extreme right side. So everything, this lead is in direct opposite direction to the axis of the heart. So usually the leads that are exactly in the axis of the heart are lead 2 and V1 to some extent, V1 and AVR, they are in the totally opposite to the axis of the heart. Okay, now please focus on this ECG, because this is whenever we talk about an ECG after the demographic data and going through just look at the ECG, the next thing that we usually read is the rate of the ECG. So in this slide we are going to learn how are we going to calculate the rate of an ECG, and learn this because I'll be needing your help in reading the rates of the ECGs in the coming slides. So focus in this one. There are large boxes. The first large box is equal to 300 beats per minute. For example, if a patient has a R wave on one big box and then the next R wave on the next wall of the same big box, the heart rate will be 300 beats per minute. Anybody who can tell if there are two boxes between the two R waves?
Second one, 150 beats per minute.
So again we have memorized this kind of table or division. So we know when it's on the first big box, it's 300. If it's on the if the distance between the two R waves are two big boxes, the heart rate is 150. And similarly, if the distance between the RR waves is three big boxes, then the heart rate is 100. I hope you all are getting it. Anybody who is not getting it? Then I don't know how to do it. Should I go in the front and make it more clear? अच्छा ठीक है, इसको फिक्स करें. अच्छा. See, there is this is a big box. I hope everybody can appreciate it's a big box. ठीक है ना? मेरी बातें समझ आ रही है ना सबको? ठीक है? हाँ. So if there is an R wave on this and then the next R wave on this, the distance between, we all know it's 300 beats per minute. The heart rate will be 300 beats per minute. And similarly, if there are two large boxes, we have memorized it. You have to memorize it. ठीक है? So 300, we don't need to memorize this. I have rationalized it or crammed it. So I know if the distance between the two R waves is two big boxes, the heart rate is going to be 150 beats per minute. Similarly, if the distance between the two R waves is three big boxes, I understand the heart rate is 100 beats per minute. Likewise, it's basically we have to divide 300 by 1, 2, 3 and 4. So after 100, if there are the distance between two R waves is 1, 2, 3, 4, four big boxes, then the heart rate is 75. And if the distance is between two R waves is 5 big boxes, then it's 60 beats per minute. Next is 50. If the distance between two R waves is 6, then the heart rate is going to be 50. ठीक है? And similarly, if the distance is 7 big boxes, then the heart rate is going to be 43. So we know it already. This is a normal sinus rhythm. You can all appreciate. So what's so special about this ECG? First, you appreciate whenever we talk, as I mentioned, after the rate we discuss rhythm. Rhythm is regular. And how do we appreciate that? Every QRS complex is preceded by a P wave. Every QRS complex is preceded by a P wave. And the heart rate has to be between 60 and 100. Anywhere between 60 and 100 is normal. Anybody who is worried that his heart rate is in 90s and it's abnormal, then let me assure you that it's not abnormal. Anywhere between 60 and 100 is normal. If it gets more than 100, then yes, it is to worry about, and if it's less than 60, then of course. Okay, so this is an ECG of sinus bradycardia, and why do I say it's sinus? Because the P wave is there and it is followed by a QRS complex, but the heart rate is low. Now, can anybody tell me the heart rate of this ECG? Yes, it's a good effort. Anybody else? Yes, this is the right answer. 50 is the right answer. The heart rate in this ECG is 50. So the patient is in bradycardia because the heart rate is lower than 60. Okay, so now sinus tachycardia. Whenever the heart rate gets more than 100, it's sinus tachycardia. And why do we say it's a tachycardia? Because the heart rate is more than 100. Now, can anybody just calculate the heart rate for me? Yes, it's a good effort. See the first, please pick an R which is directly lying on the big box. It will make your job easy. Yes, it's near 100. Almost it's 130 because I can. It's the R wave lies just beneath the 150 mark. So I would say the heart rate in this ECG is 130 beats per minute. Okay, again this is a normal sinus rhythm. We are going to talk about the rhythm now. We have discussed the rate. We are going to talk about the rhythm now. This is a normal sinus rhythm. A P wave is followed by a QRS complex. The QRS complex is not very broad, and then there is a T wave. So can anybody tell me what this rhythm is? Oh, yes, it's an irregular rhythm. And what kind of the irregularity is there? Yes, very nice. It's an irregular rhythm. So what does this make? An yes, this is an ECG of atrial fibrillation. You can see a lot of fibrillations and you cannot appreciate a discernible P wave, and then the rhythm is irregular, so it's an ECG of atrial fibrillation. This is another ECG of atrial fibrillation. So please focus on this ECG. You will come across a lot of ECGs looking like this, where you will find that the rhythm is irregular. There is no regularity in the irregularity, and you won't be able to appreciate any discernible P waves. There are some, the waves appear to be P waves, but there is no discernible P wave. So this is again an ECG of atrial fibrillation. The rhythm is irregular, and usually the heart rate in atrial fibrillation is more than 150. So we won't be going into the details. Okay, so now we will talk about the axis. For that I need to go back to the. Okay, so whenever we are talking about the axis of an ECG, we look at the lead 1 and lead AVF. For you, just remember, if 1 and AVF both are in upward direction, it's a normal axis. ठीक है जी, like 1 and AVF, if you can appreciate 1 and AVF, if they both are in upward direction, it's a normal axis. I think that would be enough for the axis, and then we'll be going back to this ECG. Can you appreciate the P waves in this ECG? Are there any P waves in this ECG? But the P waves are there, right? And what about the heart rate? Can anybody tell me the heart rate in this ECG? Well, I don't know myself. I need to count. 100, 150, 100, 75, 60. Yes, it's somewhere between 60 and 70, 75. Okay, so I think all of you can appreciate the QRS complex is quite broad. है ना? Like they all are broad. And then if you can appreciate the T waves, the T waves are not in the same direction as that of QRS complex. If you pick up any lead, the direction of the QRS complex and T wave, they are opposite to each other. So if you get any ECG that is broad like this, and the heart rate falls anywhere between 60 and 100, and the P waves are there, and so basically it's a bundle branch block. You'll first say it's a bundle branch block, and then you will decide if it's a right bundle branch block or a left bundle branch block. If you get these patterns like these in this ECG, this is the left bundle branch block. It will be more clear in the next ECG. This is again a left bundle branch block. When we are deciding, we basically focus on lead V1 and V6 of the ECG. If there are upward QRS complexes in lead V1, it's basically a right bundle branch block, and if there are upward complexes in lead V6, it's a left bundle branch block. This is a left bundle branch block because there are upward QRS complexes in lead V6. Now the rabbit ear, this is how we used to memorize it. If the right ear of the rabbit is big in the lead V6, it's LBB. If the left ear of the rabbit is big in lead V1, it's an RBB. We are going to apply it on the ECG. Just have a look at lead V1. Can you appreciate this pattern was similar to the pattern of lead V6 in the previous ECG? Are you able to appreciate it or not? Okay, forget it. If you find it overwhelming, we won't go into the details. Even if you are able to appreciate there is something wrong with the bundles, the QRS complex is broad, I think that would be enough. This is another ECG of right bundle branch block. I think it's a 12 lead ECG. This will make our job easier. Just have a look at lead V2 and V3 in this lead. This looks like the ear of the rabbit if you can see it. Just I don't know if you are getting it or not. Okay, ठीक है चलें. Now we'll talk about the ST elevation MI. I think a lot of people, most of the people are good in picking the ST elevation MIs. ठीक है जी. तो this is how, and you can see the ST segment is elevated. So anybody who can get a guess on what type of ST elevation is this? Where is the problem? Which leads are involved? Where are the elevations? Just yes, chest leads. Leads 1 में है. Basically, it's an extensive MI. There are elevations in lead V1, in lead 1, in lead AVL, and then V1, V2, V3, V4, V5, V6. It's a massive MI. Yes, it's an extensive anterior wall MI. Therefore, we have elevations in the anterior leads, and if you can appreciate, there are depressions in the inferior leads as well. Whenever there are depressions, whenever you are confused if a patient is having an MI or not, there are reciprocal changes in the leads, like inferior leads. This confirms your diagnosis. Reciprocal changes confirms your diagnosis that patient had an MI. Just look at the elevations and then the reciprocal depressions. I hope you all are able to appreciate the depressions in lead 2, 3 and AVF. This is another ECG. It looks almost similar. This is again an extensive anterior wall MI. Anybody who can tell me where are the elevations in this ECG? Okay, lead 3. What else? 2, 3. Always remember, a single lead changes in a single lead, they give no information. they have no value. Alone in an ECG, changes in any single lead, until and unless we are talking about the rhythm, it's useless, it's meaningless, we don't give any value to it. So for any changes to be there in inferior leads, we have to take lead 2, lead 3, AVF cumulatively. Similarly, if we are labeling it as an anterior wall MI, the changes should be there in V1, V2, V3, V4, at least in these 4 leads. And then if we are talking about a lateral wall MI, lead 1, AVL and V5, V6. So only if the changes are cumulative, we are going to give them value, but alone, they have got no importance. It's another ECG of MI. Anybody who can pick the changes in ठीक है, लीड 2 में है, शाबाश. ठीक है, very good. It is an inferior wall MI. There are changes in lead 2, lead 3, lead AVF, and then we also have some reciprocal changes in lead 1 and lead AVL and lead V2. ठीक है ना? So this makes it an acute inferior wall MI. Okay, so I put this slide of hyperkalemia because I understand that surgical patients particularly have a lot of electrolyte imbalance, and hyperkalemia is quite common and it is life threatening. And sometimes if patient is having hyperkalemia and ECG changes, the patient will need hemodialysis to get rid of the extra potassium in the body. So I just wanted to make you familiar by showing you 2 or 3 ECGs of the hyperkalemia. So basically what happens in hyperkalemia is the Qrs complex, it gets broad, and the T waves, they get peaked and the P waves disappear. So if you just have a look at this, you can see there are no P waves, small or indiscernible P waves. The T waves, they get tall, they become tall, and the Qrs complex, it becomes broad. So it's an ECG of hyperkalemia. The complexes are quite big and the T waves, they are quite tall. It's basically, these are the stages of hyperkalemia. If the hyperkalemia is getting worse, you will get a sine wave. So basically this is how a sine wave look like. The Qrs complex is getting broad. I hope some of you have come across ECGs like this. Well, I don't get a response, so it looks like maybe not really. So this is a sine wave. This is a dying rhythm. If a patient has hyperkalemia in a range of 7 to 8, in the end the patient gets an ECG like this, and it becomes very difficult to do anything at this stage if the hyperkalemia is so worse. So now we are going to talk about heart blocks. Should I talk about heart blocks? Like okay, a little bit I am going to talk about the heart blocks. So whenever we talk about the heart blocks, we are usually talking about the AV blocks, the atrioventricular blocks. We all know that there is a conduction system in the heart. There is an SA node where the impulse is generated and it is conducted into the AV node, and then it goes into the His bundle, and from His bundle it is transmitted into the ventricles via the Purkinje system. So the impulse is generated in SA node. Anything that causes problem, disease in the conduction system will cause problem in SA node or AV node. But whenever we are talking in general terms, we are talking about the AV blocks. We don't talk about the SA block that much. We have a patient in private room. He has beautiful ECGs of his rhythm changes on daily basis. One day he is in sinus rhythm, the next day he has first degree heart block, and then it changes to a second degree heart block. So he has really nice ECGs. If anybody of you is interested in, we have already talked about the bundle branch blocks, the left bundle and the right bundle branch blocks. So we won't be going into the details of that. So basically the distance between a PR interval is 3 to 5 small boxes. ठीक है जी, 3 to 5 small boxes is the normal distance between a P wave and a QRS complex. Anything that increases this distance will cause first degree heart block. I hope you all can appreciate that the distance between the P wave and the QRS complex is more than 3 small boxes. ठीक है? The upper limit is 5 small boxes. असल में ये distance सबका it's a first degree block. Whenever there is a first degree block, there is a constant but increased distance between the P and QRS complex. जब the distance increases, progressive prolongation, तो वो Morbid's type 1 बन जाता है. It's not the first degree heart block. This is another example of first degree heart block. This is a second degree type 1 Winky bag. I think it will be really difficult. Anu adano zaabte mashhur thet. Mas keken to trigist. Phatut thet phatut. Phatut the phatut. Bag the. Phatut the. Hatte bas masaki tha. ठीक है जी. This is a first degree block. I told you the normal distance is 3 to 5 small boxes. You just have to count these boxes. A big box is equal to 5 small boxes. So you can see it's more than 5 small boxes. So this is a first degree heart block. चल रहा है? कर सकते हैं. ठीक है ठीक है. कहाँ चल रहा है? इधर दिखाएं ना मुझे. उधर देखिए आप. अच्छा ठीक है ठीक है. ये वाला ठीक है जी. तो the distance between the P and QRS is increased and it's a constant difference. Now it's a first degree heart block. This is again an ECG of a first degree heart block. Now this is a second degree block type 1. So what happens in Winky bag or second degree type 1 is there is progressive prolongation of the PR interval which is followed by a drop beat. Look at this one. It's a perfect sinus rhythm. A P wave is followed by a QRS complex. Now just look at focus on the interval between P and R wave. Now the interval has increased. This P wave and this QRS. Again the interval has degree AV block. It's an ECG which combines all the blocks in one ECG. I think you can better appreciate in this ECG that the P waves, the distance between the P and QRS has increased in this ECG, and in second degree there is progressive prolongation followed by a drop beat, and in this second degree AV block this P wave is not followed by any QRS complex, and then the third degree heart block. Okay, let's work. I think sinus arrhythmia, I just wanted to tell you that at times it appears that the rhythm is irregular, but it's a physiological phenomena because of the breathing. There are more complexes during inspiration as compared to expiration, and there is nothing wrong in this ECG. So you can have, this is a perfectly normal ECG because every P is followed by a QRS complex and a T wave. This is a complete complex, then this is also a complete complex, and so on and so forth. So there are no missed beats just because of the inspiration, a normal physiological phenomena. You get more complexes during inspiration as compared to expiration. This is another ECG of. Okay, so if the, I think it's getting boring and it's getting lengthy as well. So should I wrap it up? Should I wrap it up, sir? Carry on.